It's a pleasure to talk to you about this very exciting and evolving topic, which is the endoscopic treatment for obesity. As these are my disclosures, I'm equally conflicted by multiple companies, so take what I say with that in mind. So my goal is not to indulge too much in the data. There is a lot of activity in this space, but rather than give you a lot of the data because it's going to be unfair for each device, I would like to give you an overview about these therapies and tell you how do I see this future shaping up for this field, and answer by showing you some of the physiology, the question, if I could do it, should I do it? So the biggest reason that we need therapies like this is this. Right now, our management approach to obesity is quite lacking. On one end of the spectrum, we have lifestyle intervention that have not been sufficient to address the magnitude of this epidemic. On the other hand of the spectrum, we have multiple effective surgical options that do offer durable and sustainable weight loss, however, at increased risk and cost. So we have two gaps. The first gap in those who qualify for bariatric surgery, 98% of them do not wish to pursue this option because of a variety of reasons. And the second gap is those who do not even qualify for surgery, but lifestyle intervention and pharmacotherapy has not been sufficient to address their disease. These are the people with BMI 30 to 40. So you could see that the pie is huge, and I could accommodate a lot of endoscopic therapeutic options. So I'm happy to say at the Mayo Clinic, in this day and age, this is the spectrum for management of obesity. When the patients enter the spectrum depending on the severity of the disease, and they're freely mobile between management strategy. That means if somebody fails pharmacotherapy, they get minimally invasive endoscopic options. If they fail that, they might consider going to a more invasive endoscopic option, and ultimately, this should be driving higher surgical numbers and higher access, because now you have sensitized the patient to the concept of a procedure helping with their obesity disorder. So overview of endoscopic bariatric therapies, the present and the future. These are not magic, and they did not stem out of magic. These come from our better understanding of this gold standard procedure, which is the Roux-en-Y gastric bypass. If you take the Roux-en-Y gastric bypass and break it down to its component, essentially the first component is a volume restriction, or a restrictive component with isolation of the majority of the stomach. What's the equivalent endoscopic options? We have two FDA-approved space-occupying balloons, a single balloon called Erbera and a double balloon called Reshape. This is coming down the pipeline. It's called a transpyloric shuttle, which is a device that intermittently blocks the gastric outlet, delaying gastric emptying and inducing satiety. This is currently in FDA clinical trials. This is a procedure called endoscopic sleeve gastroplasty, where we're using a full-thickness endoscopic suturing device. We started this procedure in 2012 at Mayo Clinic, and now we're offering it clinically. And what we're doing basically is invagination of the greater curvature, or a gastroplasty, where we invaginate the entire greater curvature to create a plication and produce an endoscopic sleeve gastroplasty effect. This is the post-procedure, where they decrease the accommodation of the fundus by placing multiple basket-anchored sutures in the fundus in order to decrease the accommodative response to food with this procedure. What about small bowel pathways? We know that part of the gastric bypass, including a bypass of the proximal small intestines and some dumping of nutrient or partially digested nutrient to the distal small bowel. However, most of the weight-independent response to bariatric surgery does not come from Roux-en-Y gastric bypass, and I will show you this results shortly. It comes from better understanding of these procedure, which is the pancreaticobiliary diversion and the duodenal switch, where you're dumping bile and partially digested nutrients into the ileum. And here is where this is coming from. So on the y-axis, this is a hyperinsulinemic euglycemic insulin sensitivity test, gold standard for measuring insulin sensitivity. And the squares in black are results from pancreaticobiliary diversion. The triangles that are clear are results from Roux-en-Y gastric bypass, and this is percent weight loss. You could see that, yes, Row-Y gastric bypass significantly improve insulin resistance. However, it's in a weight-dependent manner. However, pancreatic biliary diversion, you could see that even with minimal weight loss, there's a significant improvement in insulin resistance, indicating that there is weight-independent effect that we could capture and capitalize on clinically. And one of the procedures to capture on these effects, there we have bypass liners, like the endobarrier, where you place them into the duodenum and they bypass the proximal duodenum and jejunum. Or there's devices that could bypass, similar to gastric bypass, the stomach and the small intestines. Then we have, given that the duodenum or bypass of the duodenum is important, seems to be in diabetes control, there's devices that resurface the duodenum with the whole idea that there is diseased duodenal response to oral glucose administration, and if you burn this mucosa or diseased mucosa and it regenerates, a healthy mucosa with improved oral glucose tolerance will ensue afterwards. However, I told you most of the weight-independent effect of bariatric surgery comes from dumping bile directly to the ileum. The equivalent device is these magnetic anastomosis that you basically advance a set of magnets, one in the distal to the ligament of Treitz and one through a colonoscopy to the terminal ileum, and you create a compression anastomosis that allow, as you could see from these upper GI serieses, that allow part of the bile to bypass the majority of the small intestines and directly dump into the ileum, thus recapturing some of the weight-independent effects of bariatric procedures. So finally, this does not fit in any category. It's aspiration therapy, and where you're placing a modified PEG tube and allowing you to suction 30% of your ingested meal. This is a challenging concept. However, I think it has a clear role to play, especially in the super obese individuals that do not have any other options, because as long as you use this device, unlike other therapies where there's plateau in weight loss, this is as long as you use it, the physiology is calories out. That means it will continue to work, and it will be soon FDA approved, and I think the FDA approval will be up to 5 years of use. So what's the future? I told you, okay, we have gastric pathways and we have small intestinal pathways. How about if you combine them? You create a Row-Y gastric bypass type of physiology, and we've done this in pigs. We took 6 Osabo pigs. We gave them obesity and diabetes. This is the only pig model that develops diabetes, and you could see with high-fat, high-fructose diet, they become diabetic. Then we give them, half of them were randomized to a small intestinal device, half of them were randomized to a gastric restriction. Then at 2 months, they crossed, who got the small intestinal device got gastric restriction, and vice versa. And that illustrates the concept of pigs do not lose weight. Pigs do not, you measure efficacy, but by prevention of weight gain. And as you could see, those who got the control or were controlled, they gained 10 kilograms per month. Those who got a single device gained 2.6 grams per month. And those who got the double device gained 1.6 grams per month. In real world terms, so if you think about a balloon where you place for 6 months, and then you retrieve it and put an endobarrier, that's another 12 months, this becomes 18 months of effective therapy. So that now we're talking beyond short-term devices to more of a long-term chronic management approach for obesity. So to answer the questions, if you could do it, should you do it? I think I will answer this question by showing you the physiology of these devices and offer the concept of precision care. Now we're going to get devices. We need to target these devices to appropriate patient physiology in order to maximize outcomes. So if you think about appetite in simplistic terms, appetite is the process of satiety and satiation, and this is controlled fundamentally by 2 gastric physiological processes. One is altered gastric emptying, and the other one is altered accommodation, how much the volume of the stomach change in response to a meal. To illustrate how these devices differ than restrictive diets and to show you that they do actually work, this is one of my all-time favorite studies published in the New England Journal of Medicine in 2011. Took 60-plus individuals and put them on a caloric restriction diet and saw what happens with them on an intention-to-treat analysis over the course of 60 weeks. You could see they did lose reasonable amount of weight with caloric restriction. However, there was a slow weight regain that ensued after caloric restriction. The investigator said, okay, what's happening? Why are these people gaining weight? So one of the things that they measured is ghrelin, which is an anorexogenic or hunger-producing hormones that's produced by the stomach. The black figure is before the caloric restriction. The dotted figures are at 10 and 62 weeks after the caloric restriction. You could see that in response to caloric restriction, ghrelin at each time point is getting higher. Their desire to eat or hunger is also getting higher, and their desire to eat is also elevated at each time point. So the conclusion is there's a counter-regulatory physiologic response to caloric restriction that trigger this yo-yo dieting, where you diet, physiology is fighting you, you're hungry all the time, and now you overeat. How does these devices disrupt that? And we studied this in quite a bit detail for the endoscopic sleeve gastroplasty that we're doing at Mayo. This is gastric scintigraphy, showing at 3 hours after ingestion of 500 radiolabeled solid meal. You could see in a normal person, the majority of meal at 3 hours is emptied to the small intestines right here, and only 16% is retained in the stomach. This is the anatomical manipulation of the endoscopic sleeve gastroplasty. This is the same patient 3 months after the endoscopic sleeve gastroplasty. You could see that at 3 hours after the procedure, the majority of the meal is sitting in a small fundus pouch, and the very little of the meal have entered to the small intestines. Thus, these people could go on a very caloric restriction diet without feeling hungry all the time. So here's the satiation test showing that before sleeve gastrectomy, they consumed 1,100 calories to reach maximum fullness. Afterwards, they consumed about 400 calories. It took them 35 minutes before the endoscopic sleeve gastroplasty to reach maximum satiation. It took them 10 afterwards. So this is not unique to endoscopic sleeve gastroplasty. Here, because we participated in multiple of these device trials, including shams, we're able to have 116 patients that had 2 gastric emptying study, one before the intervention and after intervention. These got sham, these lifestyle modification. These are different dosage of botulinum toxin. This is the endobarrier, intragastric balloon, and endoscopic sleeve. You could see that all the endoscopic options significantly delay gastric emptying, and this delay in gastric emptying directly correlates in how significant the weight loss that happens with this procedure. If you did the linear regression, that's exactly what shows you that the more you delay the gastric emptying with these endoscopic options, the more you lose weight or percent total body weight loss. So I will end by telling you that the future is we're going to have multiple devices that now target specific pathways within the GI tract endoscopically, and how we maximize outcome is how do we personalize their use. This is a proof of concept study that came from the Mayo Clinic Camillary Group that took obese individuals and break down their obesity into predominant physiological trait. You could classify about 40% of the obese cohort that they have some problems with satiety and satiation based on gastric emptying, rapid gastric emptying, or pool meal tolerance testing. You could classify 40% that having some small intestinal pathway disruption, whether it's because of diabetes or microbiota or bile acid circulation. And we tend to blame behaviors on a lot of this, but predominantly only 13% had a clear behavioral component to their obesity. How about now we take these concepts and we apply them to clinical practice with these devices, and we did this. So with the hypothesis that if some of these devices are delaying gastric emptying, those who have rapid gastric emptying should respond better for these devices. And here we show that if you have, at baseline, if you have low gastric emptying or slow gastric emptier, you do not respond more than control. If you have rapid gastric emptying at this baseline, which is the highest quartile, you respond 6 times compared to control with these devices. So I'll end with this slide. So in the future, we're going to have obese patients. We could classify their physiology. If you have issue with satiety satiation, you could get one of the restrictive gastric devices. If you have diabetes, insulin resistance, we could consider magnet anastomosis or bypass liners. If you have high BMI, super obese, we could consider these aspiration therapy or one of the bariatric surgical option. And thank you for your kind attention.